Advanced Sports Med class, happy Monday. Hope you guys are all doing well. Time just seems to be flying by. You seniors, you guys don't have much time left. It's kind of crazy. Um, but, anyways, I hope you guys had a good weekend, and I hope you guys all have a good week. And we're going to just jump right into some lower body pathology. Um, So we did the intro last week, and can't wait to watch your videos on these dermatomes and myotomes. Um, I don't know. I'm sure Zach won't care, but his concussion video. He basically was by himself, so he, talked about just being with his cows and stuff. And I don't know. Maybe you could do a myotome and dermatome check on some cows. Anyways, let's talk about contusions. So contusions are just bruises, right? So it's like, oh man, you have a bruise, you're a baby, you're not playing. But these videos that are these contusions we're talking about are pretty tender, pretty sore, pretty hard to play with initially. So hip pointers and quad contusions. So hip pointers, it's a bruise to the pelvic girdle. Lateral aspect specifically. I know it's a little too thick, probably. Very painful. You'll have ecchymosis with this. You'll be tender to palpation at the iliac crest. So the iliac crest is on your pelvic girdle. So it's when you get hit, like right here. So this is your iliac crest, and so when somebody hits you right there, you don't have any padding right there. There's no muscles right to absorb that, and it's pretty painful. So tender to palpation at the iliac crest. Really, treatment for this is like just resting and range of motion. So this could take anywhere from 3 days to a couple weeks. Super tender. Quad contusions. All right, so quad contusions are common, right? You take like a knee to the quad. I'm pretty sure, Luke, did you have one of these? I don't know if you had one of these earlier this year. No, I think you just strained your quad. Anyways, he's probably not listening to this anyways. That's all right. So quad contusions, you just take like a knee to the quad and it's super painful. People call it a Charlie horse sometimes, but you just get hit, like right on the anterior aspect of your quad. And you could see, so this is a cross section of the quad, and you can see it's bruising from superficial to deep. Definitely painful. You'll have some edema, ecchymosis. It's going to be hard. It'll be treatment for this is ice, E-stem, and you want to do that with the knee in a flexed position, and you want it flexed so that the quad's in a stretched position. So if the muscle's not stretched and you just keep the leg straight, it gets super stiff. Like, so in 24 hours, people are hardly able to move their or to flex their knee. There's extra credit number one for today. So you want the knee in the flex position because you need the quad stretched so it doesn't get too tight and immobile. Some ultrasound would be good on this too, some deep heat. Labral injury. Let's talk about labral injuries real quick. So this, I know it's a kind of crazy picture, but this is the femoral acetabulo-femoral joint, right? So there's the acetabulum, and then here's the femur right there. All right, and yes, it's dislocated, right? The head of the femur would usually be in there. So the main injury we're talking about here is FAI or femoral acetabular impingement. That's the main one we're talking about. Femoral acetabular impingement, or FAI, is exactly what it sounds like. So there's between your femur and your acetabulum, there's a labrum, right? Like just like in the shoulder, that helps stabilize the joint. Sometimes that labrum can get pinched are impinged, and sometimes it gets torn. And that's what we're talking about. It honest to God, it was like overlooked for a long time, but now more and more it's starting to get diagnosed and treated properly. So MOI, so there's two main MOIs. Overuse is the number one MOI. So just people just not running too much, but just doing their sport too much. This happens a lot in track athletes and soccer athletes, but I've had kids with FAI in every sport. The other MOI is anatomical. So anatomical is like you're just born with a deformity of some sort in your hip that causes it. So now the signs and symptoms, three main signs and symptoms: anterior hip pain, back pain, and radicular pain to the knee. Now, those signs and symptoms are kind of crazy, right? And that's why for a long time it was misdiagnosed, because people thought if something was wrong with your hip, you'd maybe have lateral pain, but not anterior hip pain. They call it like a horseshoe, because it's like in the shape of a horseshoe, like in your hip. And then radiating back pain, and then pain down to the knee. All right, so treatment for this, so you always want to start conservatively and do like posterior chain strengthening, which is like glutes, hamstrings. And then some good PT is super important with this for some joint mobilizations and to help loosen up the joint. But if you have surgery, like you're talking 9 months, you're talking a while. All right. So that's FAI, or labral injuries, or those are the labral injuries. There's Kevin Ware. This is usually the time that we'd watch some pretty crazy videos. We'll probably just pass on that for now. But let's talk about fractures. Okay, so femoral fractures, MOI, it's either direct blow like a car accident or falling from a height. Signs and symptoms. So if the femur is fractured, it will be internally rotated. Is that right? Pretty sure. Yeah. So the leg will be internally rotated and shorter than the other one. So this is a medical emergency. We need to get them to the hospital right away. Right? Right away. Tibia and fibula fractures, MOI is typically a direct blow, or they have a previous condition like a stress fracture that causes the actual fracture. This is extra credit number 2. So if somebody has, like the Kevin Ware thing, right? I guarantee he probably had like a stress fracture in his tibia. I mean, it's not normal for you to just jump up and then come down and land and your tibia to crack, right? So a previous condition like a stress fracture makes that bone weak. If your tibia and fibula are fractured, you want to assess your vitals. Actually, with all this stuff, you should really assess your vitals and your nervous system. So like dermatomes, myotomes, and then this would be like pulse. But you have to check distal to the injury, right? Because if you check above the injury, then there's no injury, so nothing will be cut off. Base of the fifth, avulsion fracture, right? So this is, here are your metatarsals. So here's your 1, 2, 3, 4, 5, and this right here is the base of your fifth metatarsal. The MOI is forced inversion, your perineal muscle group. So there's muscles that come and run down and attach to there. So this is pretty there'll be a deformity. You'll be able to see it. Rest, boot, rehab. A March fracture. Okay, so a March fracture is an overuse fracture, or lack of cross training. Like this happens a lot with runners. All they do is run all year. Soccer players, and they fracture their third to fourth metatarsal. And it's like a stress fracture of it, but then it can turn into a real fracture. Tendon to palpation at the bone is the main thing. Pain with weight bearing, so it won't be too painful when they're not weight bearing. So this is something where they can kind of play potentially, but they're wearing a boot, right, all day long to protect it. Let's see here. Well, how far we got to go? Let's see. I think we'll keep going to ligament injuries. Okay, so let's talk about the ACL. All right, so the ACL, the anterior cruciate ligament. MOI would typically like be a plant and cut motion. So you go to plant and cut, and then you feel a pop. Contact versus non-contact. So a lot of times this happens with non-contact injuries, which should be preventable, right? So how do we prevent that? There should be a second thing that says here, prevention. So, oh, there it is, right here. Maybe I should bring it over here and make it a little bigger. And change the color of it. Okay, prevention. All right. So non-contact and typically women are more prone to it than males. So, and that's due to the Q angle. So that's the angle between femur and knee. So let me show you what I'm talking about. So the Q angle in females are a little bit bigger than in males because of anatomy, right? So women's hips are a little bit wider, and so the Q angle is literally here. So it's drawn from here. Whoa, I'm really messing up. Here to here. Okay, so that's the Q angle. The wider the hip, the larger the Q angle, right? Which puts stress on the medial aspect of the knee, which puts you at risk. Okay, so prevention would be to strengthen your glutes, right? Which helps with extension and abduction of the knee, your hamstrings, and then jumping and landing motion, right? Making sure the lateral aspects of your knee and your legs are stronger, and making sure you have good form, right? That's the main thing. Signs and symptoms, there's going to be a fusion, right? So a fusion is joint swelling, pain, ecchymosis, so special tests. So these are the two special tests, which is positive, well, there'd be positive anterior joint and a Lockman's test. And the Lockman's is a better test. Immobilize, and really, so this is more like 9 to 14 months now, because they were trying to rush everything, but they find that wasn't really good. So medial collateral ligament, your MCL. So typically, it's due to a direct blow on the lateral aspect of your knee. But if it's non-contact, you probably tear your ACL and your MCL together. 10 to 2 palpation at the medial knee. So this is your special test, your valgus special test. And with MCLs, you usually don't need surgery. Meniscus injuries. So the MOI is like a shearing force. So that's like a pressure and then a twisting. You have 2 meniscus in each knee. One's medial, one's lateral. Signs and symptoms, you'll have a fusion. And these are specific just to the meniscus. So joint line pain, like a catching sensation, decreased knee extension, and like a clicking. The special test is McMurray. And treatment would be non-weight bearing for a while, and then an arthroscopic procedure. And there's 2 things that they could do. They could either repair or remove. Now, I'm telling you right now, if you go to a doctor and you tear your meniscus and they're like, we just need to cut it out, right? You should walk away from that doctor. That was common practice. They would just cut out the part of the meniscus that wasn't healed up, because it, number one, so the meniscus gets torn. It's avascular. It doesn't heal well, so they would just cut the part of the meniscus out. But they're starting to find out, especially in certain populations, cutting the meniscus out is a terrible, terrible idea. It just leads to early onset of arthritis, or there's something called a chondral defect, where it's essentially just like subcartilage swelling, right? That's super painful. So it always, right? You should repair it or replace it, not take it out. 100% these days. Okay, so we want to repair, not remove. This is where we're gonna stop today, I think. No, let's just finish this real quick, okay? We could do it. All right, next are lateral ankle sprains. So we already talked about these a little bit. Before we talk, let's talk about grades. So these are the grades of sprains. So grade 1, right, irritation of fibers. Grade 2 is a partial tear of fibers, and grade 3 is a complete tear. 1 irritation, 2 partial, 3 a complete tear. So with lateral ankle sprains, super common. Remember the anterior talofibular ligament is number 1 sprained ligament. Depending on the grade, ecchymosis, edema, decreased range of motion and strength, and really do Rice and NSAIDs. I don't know if we got to say, yeah, we did NSAIDs, non-steroidal anti-inflammatory drugs. And just real quick, look, here's the progression of rehab. We're going to have a rehab PowerPoint, but I want you to know this, right? So we're going to decrease pain, edema, increase range of motion. Now, these 3 you could kind of do all together at the same time. And then you go to increase strength, first non-weight bearing, then to weight bearing, increase balance, proprioception. So proprioception is the body's awareness in space. So like if you have good proprioception, if you close your eyes when you're standing up, right, you'll have good balance because your body has good awareness of itself. And then increased dynamic ability, which is basically like plyos. And then return to sport-specific activity, which has certain steps to it as well. All right. High ankle sprain, also known as syndesmotic ankle sprains. So I think we learned about these ligaments already, right? So you have the posterior inferior tibiofibular ligament, and then the anterior inferior tibiofibular ligament. So those are the 2 ligaments. Signs and symptoms. So high ankle sprains are worse, right? So these ligaments, they keep your tibia and your fibula together. Every time you walk, so here's your tibia, right? Here's your fibula. Every time you walk, those 2 want to separate, but that ligament keeps it together. So imagine every time you walk and you're irritating that sprained ligament. So it takes a lot longer, right? Like an ankle sprain could be anywhere from, a couple days to a few weeks. A high ankle sprain, you're probably looking at a few weeks minimum, right? Honestly. And then strains. So strains are to tendons. MOI, force movement, explosive movement. Most common is definitely the hamstrings. So signs and symptoms are going to be pain with testing their strength and pain with stretching. So doing its function and then not. E-stem, NSAIDs, cryotherapy for sure. So it's the same grades, right? So if you were playing with the grade 1, it could turn to a grade 2, right? So you just want to be careful. Tendonitis, all right? Anything with itis in it, inflammation, so like overuse. Patellar is super common. So signs and symptoms, there'd be pain before and after, but better during activity. And it's better during activity because it's warm. Blood flow's been increased to it. Treatment would be like eccentric contractions where there's a contraction but it's still stretching. Okay. Thermal before, cryo after. And then medial tibial stress syndrome. So that's shin splints. And this, honestly, the MOI, there's so many things, but it could be increase in activity, decrease in activity, bad shoes, new shoes. It could be your foot. It could be your anatomy. There's just a lot of stuff going on there. Signs and symptoms would be tender tube palpation, typically at the medial tibia, slight edema. You just want to watch out if it gets tender to palpation at specific point, because that could mean stress fracture. Patellar dislocations, right? So patellar dislocations are fairly common. Typically, the MOI of a patellar dislocation is anatomical. I think most recently this happened in a hockey game to an opposing team. But essentially, your patella just shifts laterally out of place. With this, there's could be collateral damage like a bone chip or a ligament tear of your MPFL, your medial patellofemoral ligaments. So you know that ligament connects the patella and the femur. Signs and symptoms would be definitely a deformity, painful. We'll have to get a video going of that or something, maybe on our live class. And this, you're looking at 4 to 12 months, right? Potential surgery. Turf toe, which is, I know it sounds kind of silly, but it's super painful, and it's just forced extension of the hallux. And so that posterior, or the dorsal aspect of the hallux and metatarsal head is pain. You start with tape, and then if that doesn't help, you could put a plate in the shoe to help give more stability. But turf toe is super painful. So hey, good job, way to power through this. Lower body pathology, nice work. I hope you guys have a good rest of your day. All right, we'll talk to you soon.